Okay, we're live.
Thank you. Good afternoon, everybody. We want to welcome you to the COVID-19, where we are talking about steaming shots and the sangomas. This is going to be an interesting afternoon, and SACU is welcoming you all. We appreciate you joining. And my name is Cassandra Bandaguni. I am from Zimbabwe. I am one of the SACU directors. I will introduce you to the other directors. We have Rachel Ledisma. She is from the wonderful Namibia, and she is one of the SACU co-founders. And she is in finance team along with Edie Sandele, who is also in the finance team. Edie is from Tanzania. And in our wonderful event team, we have Lisa Siavong. She is from wonderful Namibia. She is our event coordinator. And we also have Omega Taonezi from Zimbabwe. Omega is in the admin department. And we have Dr. Sitinga. Dr. Sitinga is in marketing along with me. She is my co-partner in crime. And we have Nadine. Nadine is from Angola. She is in team finance. And we have one of our executive board members, Big Mike. Big Mike is in IT. He is one of our designers. So welcome, and we have our wonderful, wonderful coordinator, Toko. Toko, we appreciate you. Thank you for supporting SACU. Over to you. Thank you so much.
Thank you, Cassandra. Thanks for that warm welcome, and welcome everybody to the SACU Town Hall on COVID-19 vaccines and other options that are out there. We're at the 1-year mark of the pandemic, and luckily we have a vaccine, multiple vaccine options, and vaccine rollout has started in many areas and to some. In today's town hall, we're going to cover a number of important topics related to COVID-19, starting with what's probably on the top of everyone's mind today: vaccine access and distribution. We're going to discuss it from a local point of view within Montgomery County, as well as Maryland, as well as from the African continent point of view, specifically Southern Africa. We're going to listen to some firsthand perspectives from their experience with COVID, as well as vaccination. And we're going to dive into the medical science and public health side of the illness. Additionally, we will discuss traditional healing considerations that are specific to the African continent. So let's get started. We have a lot to talk about. We're going to talk about the disparities that we're seeing that are related to access and distribution, starting with Ms. Elisa Munthali. Ms. Munthali, welcome, and thank you for joining us today. Ms. Munthali is a healthcare policy leader and public health expert with over 20 years of experience in the field. She has worked with and served as a consultant for a number of leading public health organizations and carries an MPH, a Master's in Public Health, from George Washington University. Welcome, Elisa.
Thank you very much, Coco. Thank you to all the SACU leaders.
Elisa, we can't hear you.
Oh, okay.
Or is it just my mic issues? Cassandra, are you able to hear Elisa?
No, we can't hear.
Let's see if we can try to see if there's something we need to do on our end.
Oh, yes, I think we can now.
Oh, perfect.
Great. All right. I'm glad we sorted that out. Yeah, we definitely want to hear from you.
Issues, so sorry about that. But thank you so much for the invitation to be here. Happy to be here and contribute and listen to the other perspectives as well.
Well, we're thrilled to have you. So with COVID-19, let's start talking about the local aspect. For a number of reasons with COVID, there's inequality in disease burden and inequality in access as far as the need for vaccination, as well as getting access to treatment. Help us understand what is going on locally with that.
Yeah, thank you. I think part of the issue is that, inequality issues are systemic. When I think about health equity and putting it within the context of COVID, the COVID vaccine, the primary goal is to ensure that every person has equitable access to a quality, safe, effective, and affordable vaccine. What has happened recently is not unique. Global pandemics exacerbate the disparities and inequalities in our society, and they really create barriers to access. And you can't have health equity or parity without access. This is not just, in terms of our populations locally, but it is also in Africa and other parts of the world. It is important that we recognize that we're so much more than our interaction with the healthcare delivery system. Where we live, where we work, where we learn and play has a lot more significant impact on our health outcomes. So communities of color who are particularly underserved disproportionately are affected by disease, and especially in COVID. In large measure because of the systemic issues I mentioned before, a big one is racism and also the social determinants of health. When you don't have transportation, your food and housing insecure, you don't have employment that allows you perhaps to stay at home, you're at the front lines, you're really um, more at risk at contracting the disease, and also at risk at suffering from the impacts, losing your job, not being able to have childcare when your children are home. And that also creates additional issues around the digital divide of people that might be insecure. So there are a host of issues that are systemic in nature, and they tend to affect people who are marginalized in communities. The one last thing I will say is that, when we talk about disparities, I think what's happened with the COVID vaccine, I mean, the COVID virus itself, is that it has been extremely accelerated. And so all of the information has also been accelerated. We're reading a lot about medical science, probably more than people wanted to read, even about public health. So when we talk about disparities, it is important to remember that there is a standard of care. And what disparities means that these marginalized communities compared to a reference group, it could be by population, it could be by gender, ethnicity, nationality, they are not having the same access. And in this case, it is to the COVID vaccine.
So before we move on, Elisa, your mic is a little bit low. I'm not sure if there's anything we can do about it, or if you're able to get closer to the mic. We can still hear you, but I think for some it might be a little bit difficult to hear.
Okay.
And we don't want to miss a word that you say.
Okay, is this better?
It's a little bit better.
Okay, let me try and, I am so sorry. Is that better?
It's good for me, so let's go with this.
Okay.
Okay, so you talked about minority groups. Which minority groups in particular are being impacted?
Particularly Black, Brown, and Indigenous people, also immigrants. They may not be as connected to health services. The types of jobs that they may have, as I mentioned before, may leave them particularly vulnerable to COVID. And people who also live in areas that are very densely populated. When we talk about it at home, we may talk about people in rural areas because of access, but in a lot of places, people that are living where it is challenging. They have to go to work for their paycheck to pay for all of the things that they need to survive. They are the ones that are being affected the most. And of course, the vulnerable populations that we have all talked about, the elderly, those with underlying conditions, all of the people that I mentioned in the previous group, the communities of color, many of them do suffer from underlying conditions, and that's what makes this even more challenging. They suffer from diabetes, they suffer from heart disease, they suffer from depression. A lot of this goes unchecked, often because they don't have consistent healthcare, and they're often seeking services, um, when it's acute. And so these are the things that make them more predisposed to serious illness and death from COVID.
So it sounds like already existing inequality, which is reflected in people's social and economic status, are just being reflected in COVID-19, and if anything, making things worse. I also imagine that language barriers and literacy might be an issue. I know a lot of the information that's out there to access vaccines or informations about the disease are in English, and they're not always presented in ways that's accessible by people who might be from an immigrant community or who might be from elsewhere. Is there anything that the state or the county or the federal government, to your knowledge, is doing to address this?
They are. I think particularly, we do have a pretty sizable Ethiopian community, especially in Montgomery County. And so there are quite a few resources in Amharic, especially also with Latina groups, Hispanic groups. They are resources that have been translated to Spanish. But there, and also some Asian populations, there have been some resources that have also been translated to languages that are part of their native tongue. But it is challenging for a lot of other groups. There are many of us that don't fall within those categories. But I think the key is working with communities and people within these communities. It's not just in the language, but it's in how you translate this information. I think it's important to identify within these communities, who do people listen to? Very much like we do in Africa, we listen, when we talk about, some of the challenges in translating health information, a lot of it has been top down. It's maybe from the Ministry of Health, but sometimes, what really works is going down to the community level, going to the village, maybe working with the district health officer, or maybe working with a traditional authority, or maybe working with the chief. People that communities see that are present, that are vested in their communities and working with them. So it is about the translation of language, but it also is also how language and who are the messengers that are bringing it forward to communities.
That's great. So I think for us in the diaspora, it might be going to your faith leader, your pastor, and maybe your local community physician. I think when I think of who we listen to, I think those are the people that we might lean to. Are there other groups within our community that might be other good sources? I imagine that your friends and family members as
Yes, I
well.
think I think your friends and family members. I also think, many of us are becoming, let's say, second generation American, and for some communities, those that have preceded them, first generation, they often, if they're in a large community, they are not speaking English. They are speaking their native tongue. So definitely family members, I would say younger family members that might be bilingual within households or within communities, they would be helpful to translate some of this information, not just because of the linguistics, but also because of the media that they use. So they're more savvy with social media. A lot of messages that we need to dispel that are going through on social media, but they can access that for, let's say, their abuela, for their grandmother, or for other family members. But I think the points that you're raising also about faith leaders is really important. I was just listening to, it was a review of Biden's visit to the CDC just the other day. And the CDC was talking about putting together a number of resources, working not just with states, but also counties, related to some of the smaller ethnic and minority groups, the Filipino groups, and making sure that Asian Americans outside of the Filipino group also had resources at their ready, to understand what the risks are, where they can find information about the virus, where they can find information about vaccinations and who might be in a priority group.
Absolutely. No one should be left out in outreach. So in the way that we're seeing disparities locally, there are also similar but different existing disparities on a global scale. Let's talk about that and access to vaccines for low and middle income countries, like the countries that we find in Southern Africa. What's the situation there?
Yeah, I mean, I think it's mixed, right? So I'm not sure if everyone is aware of how most countries in Africa are getting the vaccine. Just in the way of a very brief background. So the WHO, UNICEF, the Coalition for Epidemic Preparedness and Innovation, CEPI, and the Global Alliance for Vaccines and Immunizations, Gavi, they're coordinating on what they're calling the COVAX vaccine, right? And so their primary goals are essentially threefold: to ensure that there's fair and equitable access of the vaccine to people around the world. They're also trying to accelerate the development of vaccines. We've seen that happen, but also diagnostics and therapeutics. And because this is a global issue, the marketplace could go crazy in terms of pricing. So they're trying to negotiate pricing with vaccine manufacturers. So essentially, COVAX is a consortium of middle, high, low income countries, where the high income countries are risk pooling to invest in vaccine manufacturing, with the understanding that, no country is safe until we're all safe. So in terms of vaccine coverage, COVAX is aiming to supply vaccines to cover 20% of each participating countries' population. That includes those that are most at risk, healthcare workers and vulnerable populations, many of the ones that we've talked about. But the one interesting caveat to all of this is that those that are putting in the money, so the self-financing countries, can request coverage up to 50% of their population, but only until every country has met the 20% threshold. Their goal is to have about 2 billion vaccines by the end of this year. And as you know, the US just joined COVAX after the change in administration. So I think part of the issue with COVAX, while I think the intent, was good, it is creating some significant barriers and some potential threats to African countries in the way they're able to access the vaccine. The major one in which many countries are speaking out about right now is the allocation of the vaccine. So there is growing concern that high income countries, primarily the ones that are, financing the manufacturing of the vaccines, are hoarding those vaccines by reserving more than is needed, more than the 20% for their populations from the COVAX facility. At the same time, they're entering into bilateral agreements with these manufacturers. So the supply is drying out. It's not only undercutting the initiative and the intent of COVAX, but it also is undercutting funding for middle and low income countries to secure necessary doses for the 20%. There also is some concern that because of that, there have been a number of delays in getting out the vaccine to African countries. And, Toko, you and I are from Malawi. We just got the first dose of vaccines about 2 weeks ago. It was only 360,000. We have a population of 18 million. We're expecting I think it's 2.1 million. They said by mid-March. I'm not sure if it's been delivered, but that falls far short of the 20%. And so there is growing concern that, was started by South Africa and India last year. They essentially put out a proposal to the World Trade Organization to waive intellectual property rights for vaccine patents, to allow manufacturers to share that science, the vaccine science, and accelerate production of vaccines internally, so that we in Africa can become more self-reliant. Some are pushing back because, it is, I think, I'll just be honest, I think the model right now is a very imperialistic model. And so they are pushing back at this idea of Africans being a little more self-reliant, but it is not new. At the start of the HIV/AIDS crisis, there was a waiver that allowed, manufacturers to share the science around antiretroviral drugs. Unfortunately for us in Africa, it was too late. Too many people died at that time. But we do have real life examples of manufacturers working across companies. Merck is working with Johnson and Johnson. AstraZeneca is working with Oxford. So I think there's good intention, but I think the model and how it was set up is fraught for some inherent inequalities.
So I have seen a lot of comparisons to the HIV epidemic that we experienced, in that there was a delay in waiving all these intellectual property rights and copyright laws to allow access or manufacturing within local areas in developing nations, so that that can improve, get rid of the shortages that we're seeing. But it's not happening, and it seems to be getting very politicized. Why is that? Are we all in this together?
That's the question I ask because, honestly, from a very practical standpoint, we kind of need everyone to be protected, right? So that we're all protected. But these are the systemic issues I talked about that, they are both local, they're national, and they're global. And so, there is a system that is predicated on assistance. There's a system that is also predicated on need. And, there's a lot of hope in Africa. The Africa CDC was started just less than 5 years ago, but they were very instrumental in ensuring that procurement of PPE and related material was home. It derived from home, so that they pooled their resources from different African countries, so that we could supply that to each other. And then what would, others supplemented it, but they have been very instrumental in making sure that we are self-reliant as a continent, and that we are building strong regional alliances and continental alliances. And so, this sort of system, it's a beyond I don't know if it's a hyper neo-colonial system, but it works for those that are in high income countries that rely on middle and low income countries for their survival. Quite honestly, you would hope that they would be working towards the greater good, but they're also, trying to do for themselves. My undergraduate was in political science and international affairs, and the first thing my professor said in international affairs is like, you know what, you guys are going to do great if you remember that countries do what is in their best interest. And so I think that's essentially it.
Right.
And I think as Africans, we need to come together. There's a lot of talent, a lot of great thinking. We need the resources, and we can do that if we come together as a continent.
And I'd argue that it's not just countries, it's the pharmaceutical companies who are able to lobby the political leaders and are looking at it as their research and investment went into this. But if you really do look at it, is that a lot of their raw resources and materials do come from places like India and other developing nations. And Africans are included in clinical studies, like we saw with AstraZeneca that was conducted in South Africa. So there's a lot of irony that's going on with all of that. But there are other vaccines that are out there that have been created. And my understanding is that some countries have gone directly to the manufacturers outside of the COVAX initiative. What have we seen there? Because I know there, in addition to the Pfizer and Moderna that we have here, China has Sinovac, Russia has Sputnik 5, which has been distributed in parts of the Middle East, as well as Mexico and Brazil. Is this an option for Africans, and what can we do to encourage access for African nations?
It's a great question. Both China and Russia have complained, and I think they might be right that they may be an anti-China, anti-Russia bias when it comes to regulators, so the FDA and other regulators around the world, as they may not be giving true credit to their vaccines. I think it also stems from those countries, I think traditionally have been rather closed. And so there is some skepticism, but I think there are options, but they just haven't been able to enter into the global stage. I actually don't know of, where the data is in terms of some of these vaccines. I do know that there is very high efficacy with the Russian vaccine. I think some were critical about the folks that were used in testing, feeling that many may have been forced. I think they used some in the military that may not have had a say, almost like, medical apartheid, right?
Mhm.
Not a say in their ability to volunteer or, a say in their ability to leave a clinical trial. And so I don't know if there's any validity to that, but there are those sort of questions coming up. But I do think that the market needs to be open. And I know some of the concern are some of the political economic issues that Western countries especially may have with China and Russia. They are competitors of them worldwide, and China especially in Africa. So that we have to keep in mind as well. Of course, with all of these vaccines, we want to make sure that the process by which they were developed was open, it was transparent. They had a cohort that was representative of those that are most affected by the virus, especially those that are elder, but also minorities.
Mhm.
And so we would want to see the data. So I can't speak to it much because I haven't seen the data, but I do know that there is some angst on on the side of both countries because they feel there has been some bias against them.
So from a policy perspective, what would you advise us to do to help with this issue? What can we do as individuals?
Individuals, I think we need to. I would say one thing we need to do is to try to get our voices behind this waiver from the WTO. I think what we can do is lobby or advocate with our governments. We can start also with our embassies here.
Mhm.
The great thing about SACU and other organizations that have registered, it does give you that extra leg to stand on as a representative group of Southern Africans in the United States. And, to show that you as people in the diaspora are looking for Africa to have the same access
Mhm.
to vaccines that other parts of the world do. And just because of where we live, where we work, and all of those things that impact us, that should not be a barrier. And so I would definitely continue to put pressure on our governments to, put pressure on the WTO to waive the rights, the intellectual property rights. I will also say for that issue, there's quite a bit of growing support in the U.S. Congress as well. So we live here. We are in the diaspora. We are Africans, of course, but we need to be active in the politics of things that affect us locally, but also things that affect our countries of origin.
Mhm.
And I would find out from the coalition, I think it's the Africa Muiza is a part of this, so he's going to kill me because I cannot remember the advocacy group. But they're spearheading this effort by making it an issue that is of importance to those that care about Africa in the Congress. And so it is something that is gaining momentum on the Hill. And so it would be great as citizens or residents of the United States that we show our support for that.
That's great. So we can always reach our representatives. We can always reach directly to Congress. We can reach our embassies, and you can always tweet about it because I've definitely seen a lot of that type of advocacy online. Thank you so much, Elisa. That was really fantastic, and good to know that there is something that is being done, and people are speaking about equity and access.
Thank you guys for everything that you're doing to make this an important discussion issue. There's a lot of misinformation out there, so the more real, solid, grounded information that gets out there, the better.
And we'll try to get the advisory group that you mentioned after and make sure that it's shared through SACU's website and Facebook page, for those who want to read more about it and get involved. So we urge you to get involved. Okay, so we're going to switch around a little and go from the global perspective and talk a little bit about firsthand experiences with COVID. Let's welcome Graig, Jaricha, and Zandy Smith. They're going to talk to us about what they have seen, what they have experienced, and where they are with their thoughts about COVID. We're going to start with Graig. Jaricha, thank you for taking the time to speak with us today. It's incredibly brave of you to talk about your personal experiences with COVID. We really appreciate this, and I know a lot of people listening will as well. Graig, tell us your story.
Hey everybody, my name is Graig Jaricha, and I think my story is a bit unique. If there was ever probably a person who's the worst example of getting COVID, is probably me. So in January, on January 3rd of this year, I was tested positive for COVID. And so what happened is that I was told to go ahead and actually stay home, social distance, quarantine for 2 weeks. Those are probably the most painful 2 weeks of my life so far, because that entailed me coughing, and when you're coughing, you're literally choking. You feel like you're actually drowning or suffocating. And so I can see how now, when people were told, oh, those most at risk are the ones who may have underlying conditions, I can see how somebody with asthma can pass away from this. I can see how the elderly cannot necessarily take it as good as we do. So in my experience, I was home coughing, I was choking, I was sitting in bed, literally not able to breathe. And it was miserable because you never wish that upon anybody. Not even on my worst enemy. I wouldn't think of that or want that on anybody that I know, just because the whole experience was just significantly, I think, projected within my system. I stayed home for those 2 weeks, and in those 2 weeks, I was doing everything. I was using a nebulizer. Obviously, when we have family that's in healthcare, they try to provide everything they can to you, help you to, try to get over this experience. I was also obviously taking cough meds, cough suppressants, or cold remedies. And it felt like also, you have a really terrible cold because your nose is congested and breathing is impossible through your nose. And anytime you try to lay back or anything, especially at night, that's when really apparently you develop all the mucus that slides back into your throat, so it makes you cough again. And you literally have a constant headache the whole time. That lasted for a good, literally 10 days. I had no taste. Try eating meat and soup, and you can't even taste anything that you love. And as Africans, loving the food that we eat literally kills your diet. So the whole time I lost probably about 20 to 30 pounds during that time. So that lasted probably, I'd say, a period of 2 weeks. And in those 2 weeks, the only thing that really worked well for me was when I was, in my language, say kunatira. Kunatira is when you take a blanket, you boil some herbs, and you cover yourself and just to steam it out. And so when things were at their worst, that's what I relied on to breathe. Those nebulizers, those inhalers, and everything else that they gave me at that time was not as effective in providing an immediate relief to my coughing. So that's why I would jump and rely on that as a ways of actually clearing my system. Not to shun, obviously, medical advice is great, and I believe all those things work together to help me to overcome that. But the unique thing about me is that soon after that, I was cleared end of January the 23rd, saying, oh, you're corona-free, tested negative, praises and everything. I was singing, rejoicing, thinking, hey, now I'm clear. Now, since Corona started, I've been considered an essential worker. So I work in marketing, but the company that I work for produces and sells vitamins and supplements. So obviously I was taking vitamin C. I had access to all the best supplements out there. And so clear lungs, all these products just to clear out your system of all the virus, tried it all. So that helped. I was cleared, went back to work. And surprise, surprise, beginning of this month, unfortunately, I tested positive again when I went in for a regular checkup with my doctor. And so that's because the whole time I was coughing, I was still having this cough that never really went away since, Corona happened. And so it had been a good 45 days until I said, you know what, since this cough is not going anywhere, let me go ahead and see my doctor and see if they can recommend anything. As soon as my doctor found out I was positive, obviously ordered to go back to quarantine. So as you can tell at the moment, I'm sitting at home. But I've been home now for a period of about 3 weeks. The cough is still there, and as you can hear as I talk, I tend to lose my voice. So you really don't have a means, I think, to justify or to navigate this area, because I think it's so new to all of us. And for somebody who might not have experienced it, to be told, I think, is to really, not to understand everything, because you can be told something, but until I've fully experienced all the effects of Corona and what I'm still going through up until now, I'm still on nebulizers. And my doctors have me on steroids, and that's because obviously now I'm just waiting to go back to get retested. This past week, I was really suffering. I couldn't breathe anymore. I was having a hard time at night sleeping. The headaches were there, just could not get over it, could not shake the symptoms. So I called my doctor on virtual, because now obviously I couldn't go into the office anymore since I tested positive again. So I haven't called him on virtual telehealth conference. He recommended go to the ER. So I took myself to Holy Cross in Germantown, was checked in there. And while I was in there, they were able to at least, run some chest x-rays and see what's going on. Now, during that time, the doctor who was attending to me, he was convinced, it's like, Graig, there's no way you can test positive for Corona twice within a 90-day period. And so he says, yes, I understand the results came back positive, but what I'm going to do for you instead is that I'm going to put you on a different kind of steroid, which is an oral steroid. And so now they were trying to cleanse me because they believed it was more bronchitis, because apparently certain things can develop after you've had Corona and COVID. He was convinced. He's like, Graig, there's no way, I'm telling you, there's no way you can have Corona. But I'm like, doctor, it says I tested positive. What do you mean? There's no way I can have Corona. He's like, yes, I understand you tested positive a second time around within a 60-day period. But to reassure you, you are well, we're going to treat you here. They treated me there for a few days and then released me to go back home. So now I'm at home. I've been on the steroids for, the past 3 days, 4 days. And I'm also on prednisone, which first day, you take it 6 tablets, one all at once. It's a steroid as well. I think actually it's supposed to clear out my system. And then as you graduate from it, the dosage lowers incrementally with each day. So my experience has not been the great. I don't think I know anybody else who's had Corona twice. And so I've tried everything as a remedy. I'm sitting at home. Where I come from, we have what's called Zumbani. I've done the Zumbani tea. I've done the nebulizers. I've done the steroids, taken professional medical advice, and all these things to try and get over this, because I am tired of it. But I feel like we're in such an area that is uncharted, that even with professional advice, and I do not shun professional advice, I definitely say if you're given advice by a doctor or medical professional, follow that. But even with them, I feel like also they are also navigating new territory, and so there's no roadmap to it, to say this is the path to recovery. And I'm glad for the vast majority out there who do go through this. They don't go through what I went through. So yeah, it's really something unique. And by the way, just to put this into context, I've never been sick in my life. I never had anything that I had to go to the hospital for. Never even broken a finger, nothing, not even a broken bone. But for me to reach this point now where I'm suffering with a condition, and I'm not at risk, and I'm not considered part of those groups that are at risk, it was really puzzling. You know, it left me a little discombobulated, trying to figure out exactly how do I navigate this? How do I go forward? And what does that mean for me? You know?
Yeah, well, thank you so much for sharing your story. And I'm sorry to hear that you've been going through ups and downs for the past 3 months with this. But it sounds like there are occasions when you have relief and then things kind of sometimes turn around. And we're going to give people an opportunity to have a Q&A with you at the end of the session. But thank you so much. And we just all wish you a speedy recovery.
Thank you.
Thank you. And now Zandy Smith, welcome to you as well. Could you talk to us about your experiences with COVID and vaccination? What has your story and experience been like?
Oh, hi, thank you for having me over. I haven't experienced any COVID-19 yet, but I just took my first vaccine about a couple of weeks ago. I would say it was just a personal decision that I made to take the vaccine just because of hearing like people who have experienced the pain of having COVID-19. So I hope, Graig, you feel better. I hope you get well soon. Like hearing story like Graig's story is the one that I don't want to go through that. Even though I might be like the healthiest person that I think I am, but I still don't want to go through that. I don't want to put my family through any fears of like, you know, losing me or something. We have seen like so many people have lost their lives, like so many families been grieving during this past year, and it's really hard.
Yes, it has definitely impacted lots of families. And I think at this point, it's hard to find somebody who doesn't have a family member or friend that's been impacted by it. So you looked at it, like you decided to get vaccinated. Did you care about which vaccine you got? It's not like we have a choice.
I mean,
But,
to be honest, I didn't care which vaccine I get, but I was just hoping that I get Moderna or Pfizer. And I ended up getting Moderna.
Okay, and I think the reality of it is any vaccine is better than no vaccine.
Exactly.
At all. But I think you stress the importance of speaking at town halls and events like this and encouraging others to get vaccinated as well. You know, you talked about your reasons and fear of not wanting to see your family impacted by an illness that you might get, or if things turned worse. So that's definitely a good motivation for getting vaccinated. And I think a lot of what we're seeing is that vaccines have been rolled out for a number of months now, and you know, some of the misconceptions and fears that people had about getting vaccinated are proving to not be real, to not have been anything to be concerned about. And we're going to talk more about the medical side of that later. So when you did get vaccinated, how did you feel?
I felt good about it. I did not have any symptoms after taking my vaccine. I took it, and the day I took it, so the nurse who gave me the vaccine, she advised me not to take painkillers. Like some people, they tend to be like taking painkillers just because they want to have the pain the next day. But she really advised me not to do that, because if you take the painkillers after taking the shot, so you're not giving like the vaccine to take its course. So you may kind of like suppress the action of the vaccine. So she told me not to do it. The only thing that I can do is just to massage the area where I got the shot, and use the cool compress. That really helped a lot. When I woke up the next day, I was fine. My arm was fine. I did not have any pain or muscle pain at all.
That's great. I'm glad to hear. Thank you so much for sharing your story as well. And I just want to remind everybody who's watching today that while everybody's sharing their experiences and their expertise with COVID-19 and vaccination, you're not to take this as medical advice. It's more for an educational and informational purpose. And the best way for you to get personal medical advice is to contact your own physician. But thank you so much. So now we're going to move forward to the medical side of things and talk about the science behind the COVID-19 vaccines, as well as talk about more about the medical aspects of COVID. With that, we're going to welcome Dr. Bukhosi Dube. Welcome, Dr. Dube. Dr. Dube is an internist who is a graduate of the University of Utah School of Medicine, and he's also a senior health advisor with the Oregon Health Authority. Dr. Dube, welcome.
Thank you very much for having me.
So Dr. Dube, I know that you have lots of good information from your medical experience to share with us. So I'm just going to hand over this section to you. But first, let's talk about the science behind the vaccines. What types of vaccines are there, and how did we get where we are today?
So actually, the presentation that I was asked to prepare for you guys goes into a lot of that. They're currently, at least here in the US, there are 3 vaccines available, 2 that are mRNA based and 1 that is adenovirus based. And the 2 that are mRNA based are the Pfizer and the Moderna. And then the adenovirus based one is the Johnson & Johnson, also called Janssen.
Okay, could you talk a little bit about the mRNA method? Because that's the new method that's been brought and that resulted in a quicker development of COVID-19 vaccination. How does the mRNA method work, and how does it differ from other traditional methods of vaccine development?
Would you like me to go through the presentation? Because I go through all of that in the presentation.
Yes, I'm going to hand it to you to go through the presentation that you have.
Okay, all right.
Will you be sharing your screen?
Yes, I will.
Okay.
Share screen. That. Can everybody see that?
Yes, we can see it.
Okay, all right.
Perfect.
So just real quick about me, I was born and raised in Zimbabwe. I came to the US just after high school, went to college, medical school at the University of Utah, and then I did my residency at UCLA in internal medicine. I had one of the UCLA programs in internal medicine, and I worked for about 10 years as a hospitalist, taking care of patients that are hospitalized. So kind of like what Graig described, I would be the guy in the hospital taking care of him. I also worked as an ER doctor for about 3 years. The day we had our first case of COVID-19 in Oregon, in the state of Oregon, which is where I'm based right now, I switched from hospital medicine to doing public health with Multnomah County. That's the largest county in Oregon. Shortly thereafter, I was asked to join the Oregon Health Authority, which is the main body that does public health in the state of Oregon as part of the COVID response unit. And that's what I've been doing the last year. So I have had the opportunity to speak to different organizations, different countries, different people around the world, different presidents, different ministers, different public health organizations from in this country and the world over. In part because people have taken a keen interest on how Oregon has done in the response, the COVID-19 response, and we have had some of the lowest case counts. We've had some of the lowest morbidity and mortality. So that has given us a lot of credibility in terms of speaking to how to manage this pandemic. So the objectives of this talk are talking a little bit about the vaccines, how they were developed, the safety trials that were done. I'll talk a little bit about some of the information that's out there, some of it that's true, some of it that's not. And then I want to talk about the role of sub-Saharan Africa in the development of these these vaccines and other vaccines in the past. So the term COVID-19 comes from the fact that it's a coronavirus, and it causes a respiratory-like illness. And it started in December of 2019 in Wuhan, China. Jumping right into the vaccines, pardon me. So there, as stated previously, there are 3 vaccines currently available in the US. There will be more coming, hopefully in the next 2 months. The 2 mRNA vaccines, you have Pfizer and Moderna, and then the Johnson & Johnson, which is an adenovirus vaccine. So what are the mRNA vaccines? Jumping right in. The mRNA vaccines, so actually what I should do is take a step back and talk about what mRNA is. mRNA stands for messenger ribonucleic acid. So for the purposes of this talk, and just to simplify things, I'll say that there are 3 main RNAs. There's messenger RNA, there is transfer RNA, and then there is a ribosomal RNA. Of note, there are many different types of RNAs. Those are the 3 main ones that if you were to take high school biology or biology 101 in college, that's what you talk about. And these have been around for as long as they've been living organisms. It's how bodies, it's how, not just bodies, it's how cells make proteins. So for as long as they've been living organisms, RNA has been around. RNA is actually older than DNA. So what happens is there's what's called the central dogma, which is DNA makes RNA, which then makes proteins. So I'll say that again because it's very, very important, and it's a very simple concept to understand, but it's elegant in the way it works. DNA makes RNA, which then makes proteins. So your body uses RNA, in this case, messenger RNA, to make proteins. This technology is not new. This technology is new. It's about 20, 25 years old, maybe 30 years old at the most. We've been using it to treat cancers. And it's the new kid on the block in terms of vaccine manufacturing. But it's not new in that mRNA in itself is not new in that it's been around for as long as they've been living organisms. And it's not new in medicine in that we've been using it to treat cancers. So what scientists did is they looked at the proteins that are expressed by this virus, this coronavirus. So the term corona comes from the Latin meaning crown. So it has these spike proteins on it. This virus has these spike proteins on it that give it a crown-like appearance, hence the name corona. So what scientists did is they figured out what these proteins were, and then they worked backwards to figure out which messenger RNA codes for these proteins. And so once they did that, they took that messenger RNA, surrounded it wrapped it up in a vehicle, in a transportation mechanism called, in this case, they used a cholesterol envelope. And so when they did that, when you get the vaccine, you're actually getting RNA, you're actually getting genetic material that is coated in a delivery mechanism that is the cholesterol envelope. That tells your cells, hey, make these proteins. And when your cells make those proteins, your body recognizes them and says, oh, there are these foreign proteins that we need to respond to. So your body makes a cellular infrastructure, the factories it makes the factories in your body that create the antibodies that respond to this virus. Of note, you're not getting a live vaccine. You're not getting a weekend vaccine. a weakened virus in all of these vaccines. So, and that's a clever part of it. Some of you may know the name Jennifer Doudna. Jennifer Doudna won the Nobel Prize in Medicine and Physiology last year in 2020 for CRISPR technology. CRISPR technology is taking this technology a step further. She's the one who came up with since the 80s, she's been working on this, came up with this novel way of using RNA. And that's why they gave her the Nobel Prize. It is incredibly revolutionary. It is akin to Einstein's papers or the internet, the development of the internet. This is the next revolution in science, RNA manipulation.
Great.
And hence,
thank you. That's all great history, Dr. Dube. I know we have a lot to cover, but I know what I walked away with what you said is that with the mRNA method, it does not use a live or attenuated virus. So there have been some concerns about how some of these quickly developed vaccines might give you the virus, but clearly, if we look at the science, it can't give you the virus because it doesn't have a live virus. And it also, the other thing that I'm taking away from the science part, as you mentioned, is that it's a technology that's actually been there for a while, but this is the first time that it's been applied to the COVID vaccine. And like you mentioned, that it's been used in research, cancer research, and I know it's also been used in other areas like Zika and flu and rabies. So I think that for a lot of people, there's the concern that it was developed a little bit too quickly. And so people were concerned about the safety, efficacy, or the quality of the vaccine. Can you talk a little bit about what the FDA emergency authorization meant? Because this was developed under that process and the regulatory process that it went through that can help assure some people about its safety, quality, and efficacy.
So maybe if I skip forward a few slides, I can show you how that works. Anyway, yeah. So speaking. So
these are all great slides. It does remind me of high school biology, though. I think we need a whole webinar to go through all of this on its own.
Yeah. So in terms of development, I'm trying to find the slides specifically related to the EUA, which you asked about. Okay, there. So what we learned during the HIV/AIDS pandemic in the 80s was that some companies came up with a way of developing drugs, antiretroviral drugs, that worked against HIV. But the problem was, the issue was, the FDA didn't have a way of rolling these medications out in a timely fashion. So it took close to 7 years. It was between 4 and 7 years for them to complete all the studies that they needed, even though they knew early on, within the first 12 months, they knew that these medications worked. But the problem, because they didn't have a mechanism of rolling these medications out before they felt comfortable with these medications, and Anthony Fauci was there. He was one of the people who was involved in that process. A lot of people died unnecessarily, and a lot of people were infected with HIV/AIDS in the US and the world over unnecessarily because they didn't roll these medications out quickly enough. So the lesson that we learned, at least from a public health standpoint, the lesson that we learned from that experience was, hey, if we have medications or vaccines or therapies that work, and we can show that they work, what we need to do is we need to have a mechanism of rolling them out in a timely fashion. So what the FDA did was they created this mechanism called the emergency use authorization, which simply allows medications and therapies, including vaccines, to be rolled out in a timely fashion so that people are saved. so that people don't have to suffer through the disease, so that people don't have to die unnecessarily. And that's what the EUA is. There are several different mechanisms that are built in to ensure that people don't get, to ensure that these therapies are safe. There is the VRBPAC, which advises the FDA. And then there is the ACIP, which advises the CDC. The Western states created their own layer of evaluation. I've had the opportunity of sitting in on this committee, the Western States Vaccine Safety Committee. And all three bodies have given their thumbs up in terms of the safety and effectiveness of these vaccines.
That's great. And so when we think about the effectiveness of the vaccines and the new variants that are coming up, I know some of the companies are creating booster shots that people might be given. And I know there is some coverage that's provided, even though the original vaccines were studied outside of the new variants. What can you tell us about the new variants and the effectiveness of current vaccines?
So there are three main variants out there. There's the UK variant, the South African variant, and the Brazilian variant. And of note, these are named for where they first popped up. In the last month or so, there have been two other variants that have been identified, the California variant and the New York variant. So these variants have an unusually large number of mutations. So of note, whenever viruses replicate, whenever cells replicate, including your cells, my cells, cells found in fish, in monkeys, in viruses, in bacteria, whenever they replicate, there's always a chance of a mistake being made. And there are some systems that are better at catching those mistakes, and there are others that are not so good. In humans, we have a really good proofreading editing system that catches mistakes and destroys whatever proteins are made as a result. In viruses, they don't have as good a proofreading system. So that allows for mutations to occur. That's essentially what mutations are. It's that that change in genetic material. So these variants have an unusually large number of mutations that allow them to more easily and more quickly spread, leading to more and more cases, which cause a greater strain on the healthcare system, which cause more people to be sick and more people to die from that. So there's good data right now coming out of Israel showing that the Pfizer, they looked at primarily the Pfizer because that's what they've had access to in Israel, looking at its efficacy, its effectiveness against the UK variant, and there is sufficient evidence to show that it works very well against the UK variant. So of note, as stated in the slide, there's no evidence to suggest that these vaccines don't confer immunity against these new variants. There's a lot of data coming out, and things are constantly changing. In a week, we may have new information, different information showing otherwise. But as of now, you are protected if you're vaccinated with the three vaccines that are currently available in this country.
So if we look at effectiveness and it preventing the occurrence of existing variants, how else do the current vaccines impact the severity of the disease? If you do get vaccinated, are you lessening your chance of disease burden?
Yes, you are. So as stated in early on in the first few slides where I was talking about how when you get vaccinated, you develop, your body develops the cellular infrastructure, the cellular factories to respond to the virus. So when you get infected, if you were to get infected after getting vaccinated, you already have the groundwork. You already have the infrastructure to respond quickly, such that your body quickly ramps up the production of these antibodies to fight the virus. And as such, you don't get sick, and as such, you don't get you don't pass on the virus to other people. Well, your period of infectivity and your period of transmission is significantly lowered. So we don't have clear data just yet to say how much that period of transmissibility is reduced, but we know that it's reduced, and hence, if you're vaccinated, you can go out and have coffee. You can have small gatherings with other people who are vaccinated.
Mm-hmm. But we're still being told to wear that mask and social distance, which is,
Yes.
I think, a good reminder for us all. Is there anything else about the science and medicine of the vaccines before we wrap up this section that you think is important for us to know?
Well, so I want to go back to the issue of, I realize that there's a lot of misinformation out there. And I realize that a lot of people don't understand how these vaccines work. And I think it was the first speaker who said that people are reading more about science than they ever cared to.
Yeah.
So what I would say is, I've seen, being Zimbabwean, I belong to a lot of chat groups from people that I went to high school with, or people that are living in South Africa and in Namibia, in the UK, in Australia, everywhere, in all over the world, right? And I see these messages coming through that have a lot of at times very disturbing misinformation. I'd say reach out to your reach out to your physician or your primary care provider, and ask questions and engage your primary care provider, such that you don't end up being misinformed. You don't end up not taking the virus not taking the vaccine because you've been misinformed.
Absolutely, absolutely. Tackling that misinformation is so important. And Dr. Dube, I think everything you've presented is just so on point, and just is presented in a way that makes it able for everybody to understand, which is fantastic. And if you're willing, and if the SACU board members are open to it, I would love to have you back for a whole hour so that we can go through this in detail, because I think that the type and level of education that you're providing really helps people understand what's behind the vaccines. And I think when you understand more, it's better for you to make a good informed decision. So I hope you'll be open to coming back for a whole hour to go through all the other great items that you have. Not to put you on the spot. So we're kind of running low on time. So we're going to move on to the next topic that we wanted to discuss with you, which is the history of medical apartheid in the African community and how that has contributed to vaccine hesitancy. We wanted to talk a little bit about the clinical trial process, but we won't have time here. So hopefully we'd cover it in another area. But there has been a history of unethical medical experimentation, either at the clinical trial level with Africans and African Americans, or different parts of the medical system and procedure. This has understandably resulted in itrophobia, which is the distrust and fear of healthcare systems by members of some community. Before, we had Ms. Elisa Munthali talk about how African, Black American, and Latino populations have the higher inequalities. And I'm sure that's something that contributes to this as well. Could you talk a little bit about medical apartheid and how that's impacting the coronavirus pandemic today?
Yes. I stopped sharing my slides. Actually, the next slide after the one that I was talking about goes into detail about that. If I can share my slides again.
Yep, you should be able to hit the share screen button at the bottom. You're also welcome to just talk through it without presenting your slides.
Yeah, well, the slides are actually, yeah, so I'm a very visual person, and I think it sticks better if it's presented. Wait a minute. Show presenter view. Okay, there.
Yeah, we can see it.
Yeah. So it's understandable that a lot of people have a lot of distrust of the system, of the medical industrial complex. And as a physician and as someone from Zimbabwe, I have seen this happen over and over again, right? It's past injustices and current injustices. There is the AZT trials that happened in Zimbabwe back from 94 to 98 when I was in high school. This was a trial to look at vertical transmission. Vertical transmission is when HIV is passed from the mother to the child. And at that time, we knew that AZT prevented, it dropped your viral load so low that you didn't transmit HIV to other people, whether via intercourse or by extension via mother to child. But they still did this trial from 94 to 98. And what led to it being stopped was that there was a large public outcry of people saying, hey, this is unethical. You can't enroll people in a study. You can't coerce people into a study that's like this when we have enough data to say that this works. And they enrolled, I believe it was 17,000 women, half of which got AZT and the other half did not. So there were 8,500 kids who were born with HIV/AIDS because of the U.S. medical industrial complex that was conducting this study. Of note, they were running a similar study in the Philippines at the same time, and following that large public outcry, people stopped. That study was stopped. Same thing with the Trovan clinical trials in Nigeria, where Pfizer was developing an antibiotic to treat meningitis, and at that time we had a treatment for pediatric meningitis, which is ceftriaxone. We still use it to this day. What happened was they went to Nigeria, coerced these women into enrolling their infants in the study, and what ended up happening was there were kids who got the Trovan antibiotic, and there were kids who got ceftriaxone. The kids who got ceftriaxone did just fine. The kids who got Trovan, because it didn't work, ended up with severe mental issues, severe neurological issues, and some of them even died. So you can understand why there is this mistrust. The three photos that I have up there, Henrietta Lacks, I'm sure some of you have heard of her. She's a woman whose cells were harvested without her consent when she went to Johns Hopkins for medical care back in the 1950s. And her cell line has been used. So before I went to medical school, I was in a PhD program doing molecular biology, genetics to be specific. I used her cells. I had no idea that they were her cells. That cell line has been around for as long as, ever since they were taken out of her, without her consent, without any compensation to her or her family. Then there's the Tuskegee syphilis trial right below her. This was at Tuskegee University in Alabama, and they looked at the progression of syphilis in black. They wanted to study the progression of syphilis in human beings, and so they coerced this man into participating in the Tuskegee trial. So it went on from 1932 to 1972, and back in 1996, Bill Clinton, who was president at the time, made a public apology to these men. So the mistrust is well earned. The mistrust of the medical system is well earned, and because of these practices. The last picture there is Dr. J. Marion Sims, who was also in Alabama, developed a lot of gynecological procedures and instruments that are still being used to this day. Women are benefiting from the advances that he made, but they came at the expense of Black women whom he performed these surgeries on without their consent, without at times without anesthesia. So incredibly amoral. To say immoral would be incredibly generous. It's amoral and unethical. However, we still need to realize that we are being affected at much higher rates, right? If you age adjust the COVID data, what you will see is that Black folks are affected a whole lot more than any other group. Black folks are dying at higher rates than any other group. In the state of Oregon, Black folks are dying at about 3 times the rate of Caucasians. The Latinx community is dying at about 3 times the rate of Caucasians. The Asian and the Pacific Islanders and Native Hawaiians are dying at about 17 times the rate of Caucasians. And it's the same countrywide, right? So our life expectancy has gone down from 75 to 73. It's the largest drop of any group in the US.
Wow, that is definitely a huge drop. But it's all painful to hear, including the history behind all of these experiments at other people's expenses, but they're important to hear and explain a lot of current situations. We need to move along to the next topic, where we're going to talk a little bit about traditional African healing methods, as well as contributions that people within the African continent, sub-Saharan Africa in particular, have contributed towards COVID-19. Dr. Dube, we're going to ask you to start off, and then we're going to move on to Baba Kanyezi. So we have a little bit of time left, and if you don't mind, if we can move forward and just talk about, I know Madagascar has had a COVID organics thing that they had brought forward, and we heard a little bit before from Craig when he talked about the steaming method. That's part of a traditional thing that he was familiar with. So if you could talk a little bit about that. And I know it uses eucalyptus or blue gum, which is also impacting deforestation. If you could just quickly go through that.
So real quick, I'll give you guys the quick and dirty version of it. So we have been in Black Africans, sub-Saharan Africans, have contributed significantly to the production of vaccines, whether it's Ebola vaccine or it's the COVID-19 vaccine. The Johnson & Johnson or Janssen had about 19% of the participants being people people that look like you and I, Black people. Most of those were in South Africa. So they had 40,000 people participate in their trials, right? So about 19%, 20%. So 1 in 5 were Black people. And most of those were in South Africa. So there's been, we contributed significantly in the production of this vaccine. There has been a lot of talk about traditional medicine, traditional healers. it's important to note that in some parts of sub-Saharan Africa, traditional healers are still the primary contact and the first contact of the healthcare system for a lot of people. As such, they have to play an important role in treating and managing this pandemic. So it's important that we work as a team. As of now, there have been 0 studies to show that a lot of the traditional methods like blue gum, eucalyptus, and other herbal plants work in the treatment of COVID-19. My mother does this. My mother is based here in the U.S. and she buys into this and she does it. And what I say to her is, hey, if it helps you, if it makes you feel better, then more power to it. Do it. You should do it if it makes you feel better. But the important thing to note is there have been 0 studies to show that this works, to show that these treatments work. And that's all I'll say with regards to that.
Okay, thank you so much. But I think we have a lot of anecdotes from people who have used this method and how well they have helped them with treatments to symptoms that they have exhibited. So definitely not something to be looked over, but maybe an opportunity for us to look into ways that we can encourage more study and inclusion of these types of treatments. Thank you so much for that. And again, so much really good and important information that I wish we had more time to go through. So we're going to welcome Baba Kanyezi. Baba Kanyezi is a man of many gifts. He is a teacher and also a South African-born Sangoma who can share with us from the traditional perspective about what it means to be a Sangoma and to incorporate traditional medicines within his practice. Baba Kanyezi, are you there?
Are you passing it on to me now?
Yes.
Oh, you were supposed to unmute me, so but it's all working.
Oh, apologies.
It's okay. Greetings to you all. What a very, very well-spoken people. Very, very great information that I've heard here or that we have received. Now, I don't think there's much to say except that, what I can just say is people, you just have to be who you are, believe in what you believe. I personally have not taken the COVID vaccine, and I do not believe that I will take the COVID vaccine. I do not even take the flu shots because I've tried it and I got very, very sick. Now, the gentleman who just spoke, Dr. Dube, he's mentioning that there hasn't been there's a 0 track record that shows that the traditional methods are working and all that. And by that, I would like to say, Graig, the gentleman who spoke before, he is one number that you can count on that says like when he used the traditional ways of healing, he's seen the improvement in everything. So I would say both methods, they work. It's all up to you. Which one do you get into first in order for you to like get your healing? Everything, like we say, prevention is better than cure. Traditional ways of healing or traditional ways of doing things is we work on things by preventing matters before they happen. You know which herbs, which things to drink, what to do, when to do it, how to do it, and then you prevent things before they happen to you. So I think that's all I can just say. If people have questions, maybe they can ask me questions. I don't talk too much, basically.
Okay, well, thank you so much, for sharing your input. And I think that Dr. Dube was alluding to the same thing that you're saying, and that he was, from the way that I heard it, and correct me if I'm wrong, Dr. Dube, in that you were talking more about the clinical trials not clinical trials, or the research that's been conducted with traditional methods. Not that he was in the camp that he doesn't believe that they're valuable or not useful. So I think for everybody, I think the important thing for everybody is to make sure that you educate yourself on what Western or current medicines are being presented and how effective they are, as well as educate yourself about what traditional methods there are and how effective they are. I just, from what I hear is that I think everybody was kind of saying the same thing. Sorry, I interrupted you. You were about to say something.
No, I was saying that, like with clinical, like trials and tests and everything like that, we have to remember that, those clinical trials, they are made based on people volunteering, right? Mm-hmm. Now, we have to ask ourselves how many of the traditional healers they have brought forward to, say these are the herbs or these are the stuff that I use for the methods of healing when it comes to certain things. Mm-hmm. So we have to remember that, like some of the clinical studies that are made, they are made by observing, however, when you come to Western medication, the clinical studies, they are done in the lab. So the traditional healers, we're not the lab people. Our track records based on who you have helped. You can mention like the number of people that you have helped. That still won't be considered as a clinical studies and all that. They probably will tell you that is luck or anything like that. But our track record is based on the number of the people you have helped who on the clinical studies, they are not being, they don't have the database of and all that.
Good point. Thank you for that.
Thank you.
Thank you. I think what we're going to do now, because we have so little time, is we're going to open it up. I'm sure a lot of people have lots of questions. We've seen a couple that have come in for all the panelists. So what we're going to do is, if you have we're going to ask you to keep your mics on mute. And if you have a question, is to raise your hand through Zoom. And then we will just signal that, it's your turn to ask your question. And if you're on the phone as well, we'll open up a time for people who are on the phone to ask questions. With that, one of the questions that I saw come in through chat talked about being vaccinated, and maybe this one's a good one for you, Dr. Dube. They were asking that if you're vaccinated, should you hang out or interact with people who are not vaccinated? Are the people who are not vaccinated putting the vaccinated people at risk? Or should you only hang out with other vaccinated people if you're vaccinated?
So, you can hang out with people who are not vaccinated. You just have to be, there has to be an understanding that one, it's a small group. Two, those unvaccinated people are low risk. And I think Dr. Fauci would back me up on this. Actually, I'm actually quoting him. He's the one who said that about 3 weeks ago.
Okay, good to know. So it's all about understanding your risk with whatever it is that you're doing, is what it sounds like.
Yeah.
Mike Hove, I see that you have your hand raised. You could go ahead and ask your question.
Hi. So my question is either going to be answered by Elisa Munthali or Dr. Dube. It's about the information that they're distributing about COVID-19. So when I look at countries like Zimbabwe and South Africa that have received an abundance of COVID-19 vaccines from China, India, and Russia, which are in distribution as we speak, there's a lot of resistance from people on the ground, including from medical personnel. The biggest reason being that they're saying they're not receiving enough information on these vaccines that they're receiving. If I'm going to use Zimbabwe as an example, they've received the Sinopharm vaccine from China. 400,000 vaccines have been given to the country. This program has been running for a month, but only about 42,000 have taken it to date. So what I want to understand in such a circumstance is, what is the best way to ensure that people on the ground can want to take the vaccine, and who are they supposed to turn to for this information? If you get, for example, the frontline workers are also resisting taking the vaccine.
Great question. Elisa, do you want to tackle that?
Sure, it is a really good question. You know, we're having the same issue in Malawi. This is with AstraZeneca, where just yesterday and the day before yesterday, a number of nurses have refused to take it. So these are the people at the front lines that are more in danger of perhaps contracting it. But you know, they're hearing some of the reported issues with blood clots, right? And some countries halting, administration of the vaccine. I think, as we are thinking about the rollout, you can't just think about supply chains. You can't just think about the allocation. I think it's very important, especially in Africa. Things need to be very transparent about who's in the, prioritized groups, so that people are not jumping lines and things like that. But you have to have a very robust, communication plan. As Dr. Dube was saying, and as I mentioned before, it is reasonable for people to be fearful of the clinical care delivery system. These sort of things that have endangered our lives have been going on for a very, very long time. And they're not only historic, they are people's lived experiences. We talk about, maternal mortality rates, let's say for Black women in this country. They are mirroring rates of developing countries. That is controlling for education, controlling for socio-demographic factors. So a Black woman that may come from low income area versus a high income area may have the same maternal mortality rate. There's something going on there. And we have to call these things out as racism. So I say this to say that we need to be very honest about, what the issues are. Call out these, whether you call it medical apartheid, call it racism, but also be honest about, yes, there are some concerns with this vaccine. There have been some reports of this happening, but we need to be very, very, it's the responsibility of the Ministry of Health. They can say, yes, we're getting our, vaccines from COVAX, but ultimately the Ministry of Health with the community leaders, with, champions within the medical facilities need to be in charge of the messages that go out to encourage people that the benefit of taking the vaccine far outweighs the harm. But we need to call things out. Like, we need to be very real, not just say, yeah, it's better for you. Say, I recognize it, it's a reasonable concern, and then have, communication strategies to deal with it.
Absolutely, I couldn't agree more. And I do think it's important to acknowledge the reasons that people are hesitant or are using a wait and see attitude, and also to not dump everybody into like a label that says they're hesitant. Because I think once you do that, you're sort of lumping them together with maybe anti-vaxxers, but that's not really the situation with everybody. There are people who do have that mistrust and are waiting to see and have other reasons for not jumping into vaccination right now.
And I think, sorry, I think the other thing is, we need to say that it's a good thing. There was this crisis that happened here in the world, and we were all, fighting against time. It's amazing the medical technology that's happened with vaccines. And I think we need to be very clear that, for the purpose of expediency, that the science was not compromised. In fact, maybe we found smarter ways, to develop these vaccines, that things were done perhaps not, they were done concurrently and not sequentially. And so be as specific as that. It takes this long to do it typically because we're waiting for this. I think Dr. Dube talked about this in terms of HIV/AIDS and some of the ways in which the process for developing this and, the outcome in terms of mortality and how it affected Africa. But I think, talk about, we know we can do it faster. And it wasn't at the expense of safety and efficacy.
Very important point. Dr. Dube, you were about to say something as well?
Yeah, man, Miss Elisa, you just hit it on the head, right? So I go into this in my talk. In the presentation, I have 3 or 4 slides specifically speaking to the safety and the trials and who was in the trials, who was included, etc., etc. And Yeah, so I go into the talk, and sorry, because of the nature of this conversation, I wasn't able to give you the full deal. But what you said is perfect, right? We need to talk about these things. We need to understand where people are, meet people where they are, and then respond to whatever issues they may have. The other thing that I wanted to bring up, Ms. Togo, is that the language we use is very, very, very important. When we talk about the vaccines, when we talk about the coronavirus, we have seen most recently how the rise in Asian hate has gone up because of the language that has been used, right? The Wuhan, China, the Wuhan flu, the Kang flu, etc., etc. Same thing with the vaccines, right? When we talk about vaccine hesitancy, we make it seem as though there is something wrong with the vaccine. Mm-hmm. It's not hesitancy, right? It's confidence, vaccine confidence. It's the language we use is very, very important. I'm reminded of the book 1984 and by George Orwell. And if you haven't had a chance to read that, you should read it. And anyway, I get very philosophical, so let me stop there.
No, thank you so much for that. And yeah, it's as a communications person, the language that we use is very important. And I know, I think a lot of people did not understand when you hear emergency use authorization. I feel like that's something that might need to be rephrased, because that's something that triggers people to have different associations. Or with the prior administration, we had Operation Warp Speed, which also might bring about associations that make people not understand, you know, what Elisa pointed out, is that there were no corners that were taken or shortcuts, and that everything that we usually do with safety, efficacy, and quality was still followed. It's just that we put a lot more resources and collaborated to get something done, which shows what we can do as humans when we work together. Now let's move on to the next question that we have. Rachel, I noticed that you had your hand up for a while.
Jama. Hi, everyone. My name is Rachel, and I have a question for Dr. Dube. I'm one of the board of directors for SACU, so thank you so much for being a part of this. I'm in the health field, in a health and wellness field, so my focus is on preventing diseases. And just like Baba Kanyezi, I'm very anti-medication, anti-vaccinations, because I really believe in my body's ability to heal itself. So how I ever get sick, I took the flu shot once and I got sick and never took it again, and that's back in 2000. So I don't plan on taking this flu shot at all. And my family, we don't take flu shot. We don't take any vaccinations. We don't even do medications. So for someone like me who's out there listening to your conversation, how can you convince us to take this vaccination? So far, by God's grace, we didn't get COVID-19. We've been doing everything, social distancing, wearing our masks, doing everything that we've been asked to do, and we did not get the virus. And that's also by God's grace. So right now, my family's focus is on nourishing our bodies, exercising, eating healthy, doing our supplements, taking the holistic approach. So if I'm doing everything right, that I've been doing so far for the last 1 year, and I haven't gotten COVID-19, my family has not. So how can you convince me to put this foreign vaccination medication to my body, which might weaken my immune system? How can you convince me to take it? And also understand that even when you take it, you still could get sick. So why can I not just keep doing what I'm doing, social distancing, eating healthy, exercising, keeping my circle small, doing everything that you're telling me to do other than take the vaccine? So how can you convince me, someone who's like me, in my shoes, listening to you right now? How can you convince me to take this vaccination? You don't have to, it's a personal choice, but I know we're here to convince people to make an informed decision. And I listen to you and everybody else, and I'm still not convinced. So please talk to me. Thank you.
Dr. Dube.
So thank you very much for that question. I love it when people are authentic, when people are real. And Ms. Rachel, thank you very much for being authentic. Thank you very much for being honest and putting yourself out there and allowing, being vulnerable to all of us. So I really, really appreciate that. It's something that we I can tell you as a physician, as a hospitalist, as an ER physician, what I've seen in the past is people are most authentic, people are most themselves when they're faced with their own mortality. So thank you very much for being upfront like that, while not being faced with your own mortality. So to speak to your concerns, you brought up that the vaccine may weaken your immune system. It actually does quite the opposite. It does not weaken your immune system. What we should be very clear about is that there is no cure for COVID-19, right? There is no cure out there. What we do is we do what we call supportive care, things that help you. If you're short of oxygen, you get oxygen. If you're short of, your blood pressure drops, they give you IV fluids to try and raise your blood pressure. They may even give you medications to raise your blood pressure. What the vaccines do is they prepare your body to fight the virus, which is what supportive care does. It simply gives you the opportunity to fight the virus. The vaccines, all 3 vaccines that are currently available, they teach your body how to make the antibodies that would fight the virus in the event that you were to get it. To speak specifically to other concerns that you may have, it sounds like you have made up your mind that you're not going to take this vaccine, which is totally fine. What I love about this country is we have autonomy. You can choose to engage the medical system. You can choose to engage it at whatever level you want to engage it at. And that's totally up to you. That's your prerogative. What I would encourage you to do is continue doing the things that you're doing, the 5 things that the public health system has been talking about, which is physical distancing, wearing your mask, avoiding large crowds, good hand hygiene, avoiding travel. Those things will protect you, and of course, keeping a small cohort. Those things will protect you from potentially getting the virus. I would, however, if I were your brother, if I were your child, if you were my mother, if you were my sister, I would strongly encourage you to take the vaccine, because it is safe, it works, and it works really, really well. It uses the body's own infrastructure to respond to this virus. I don't think I've convinced you in any way. What I want to do is to give you the information to make an informed decision.
Thank you so much.
Dr. Dube.
Yeah, thank you. I appreciate it.
And that really jumps off of the federal government's current vaccine campaign. It's called It's Up to You. And I put a link in the chat, and it really does focus on everybody having, their right to make an informed decision. And that if there are people like you, Rachel, who either have already made up their mind on where they stand with vaccines, or others who are who haven't really made up their mind but are looking for answers to questions. It's a link that has a lot of good information, and it's a campaign that's organized by a large group of individuals. So it's not just coming from the government. So I would encourage you to look up for It's Up to You, the campaign, and to look at the resources and the information that's shared there. We have another question that's coming in, and you've had your hand raised up for a while there. So I just want to make sure that we get to you, Baba. If somebody could allow him to speak, Baba Kanyezi.
All right, so the name is Baba Nkanyezi. I know it's a difficult name, but it's okay. So it's not a question per se. I also just wanted to, back on what Lisa, what she what she mentioned and to the question that the gentleman he had asked about African people, taking the vaccine. If I still have that video, I will share it with Rachel so that he can share with the community. You have to remember that some of the African countries, they've received some of the vaccine that says this vaccine is not to be taken by the US countries, European countries, only like literally it depicts only African countries they should take that vaccine. So that's why a lot of African countries, they're hesitant to take in the vaccine. Again, if I still have that link, I will share it with the Rachel so I can share it with the committee. I just wanted to add on that. Thank you.
Thank you. Yeah, that's really important. And I think maybe a part of it might be because drugs are approved separately for different countries. So even though you might have a drug that's approved in South Africa, they go through different approval mechanisms that are specific to that country. So it may not be that all Pfizer vaccines are only made for the US, but it's just the specific production matches what regulatory facilities that are available in that country. And I don't know the situation, but I just wanted to throw that out there for consideration and for thought. Do we have any questions from anybody who is on the phone? Just want to give you an opportunity to be heard as well. Okay, if not, then we're all short on time. So I'm gonna open it up to any of the panelists who spoke today. If there's a final thing that you would like to say, I'll just give you like a brief second to go ahead and say something before we wrap up. Okay, it looks like we had a great discussion. And Dr. Dube, I saw that you just got on. Was there final words that you wanted to share with us?
I was just going to say that thank you very much for having me on this panel. It's been a pleasure and honor to speak to my fellow Africans. It always gives me a lot of joy to participate in situations like this. I would like to. It's not my job to convince anyone to do one thing or the other. What I ask of you, what I implore you, what I beseech you to do is get as much information as possible, check your sources, and make sure that you make an informed decision.
Great, what a good note to end on. And thank you, Dr. Dube. Thank you, Elisa. Thank you, Graig. Thank you, Zandy, and everybody who spoke today. This has been such an important topic, and I hope that we have other opportunities to speak with everybody that's participated. It's so important, and I know that there are probably a lot of issues that we didn't cover to the extent that we could have and would like to cover them. But with that, I just want to let you know that some of the resources that we talked about were shared through chat. A recording of this webinar is also going to be on Facebook if you want to re-share or watch again. We'll also have information on SACU's website where you can find bios, and you'll be able to contact everybody who spoke, as well as other resources are there. Thank you so much, everybody, for being part of this great discussion, and have a good evening.
Thank you, everybody, for your time. Appreciate it. Bye-bye.
And thank you for having us.
Thank you.
Thank you for the event. This was good. Very informative.